guess not then. So this is a case shown to me by one of my colleagues, Reza Gassemi, and this is a 39 or 40-year-old woman referred for pulmonary hypertension. And we've got exams. This is 2017, 2018, and then 2020. The bottom two images, this is are from an inspiratory-expiratory study. So this is, I think, the expiratory phase, and this is the inspiratory. And she's got really high right heart pressure. As you can see, the pulmonary artery is enlarged. Nothing that we could find that looked like a compelling evidence of CTEPH or with any sign of chronic thrombus. But she does have these pretty extensive peripheral reticulations, predominantly in the lower lobes, then also some thickened globular septae present in the upper lobes, and a small amount of mediastinal and hilar lymph node tissue. And that's been stable over a few years now, all those findings. So we don't see many of these, but we're thinking this is probably going to be one of the PVOD or PCH. The pulmonary veins are normal, and she had a normal left heart cath previously.
Yeah, agree. Nice case.
Brian, can you scroll through a little bit slower in the lung window, in the lung bases on the inspiration?
There were some areas that were more central lobular ground glass on some of the prior studies that we thought were probably just some either plexiform arteriopathy or hemorrhage. Doesn't look like it was present on this one, or at least not. Yeah, like some of this. But yeah, it was just interesting how almost tree and bud some of the lower lobes look.
You wonder, I don't know, I can speculate that, first of all, it's an odd appearance. Yes, there are some thickened interlobular septa, but is there a possibility that there are small nodules on the pleural surface suggesting that perhaps some of them in the lower lungs represent transpleural collaterals from chest wall vessels?
Good question. Let's see.
Some of them seem to be almost tubular, small tubular structures, perhaps. Well, there are septal lines, to be sure.
Well, these ones here look a little bright. There's contrast on that study. Give me a moment. Let me see if I can find a corresponding non-contrast image.
Hard to say. I would have to look at it.
So I wasn't familiar with that entity. So is that something commonly seen with severe pulmonary hypertension?
Sometimes one can see that if there are a sufficient amount of obstructive small vessel disease, you can get collateral vessels from systemic vessels that go through the pleural surface to anastomose with pulmonary artery segments.
Interesting. You know, we hadn't appreciated that earlier, but we'll have to take a closer look. Thanks for pointing that out. So the next case, this is a gentleman with sarcoid, pretty bad chronic sarcoid. You can see this is a comparison exam from 2013 on the bottom. So lots of end-stage fibrosis involving the upper lobes. And at somewhere along the course of his sarcoid treatment, sarcoid became relatively quiescent, but he developed an aspergilloma in one of these cavities at the left upper lobe. So he was starting on voriconazole therapy. So this was kind of a subtle finding that one of my MSK colleagues helped me with the diagnosis. This is hyper-fluoridosis related to voriconazole therapy. And he's been on voriconazole for about 2 years now. And this is a commonly seen phenomenon that they see where the voriconazole, I think it leads to increased fluoride retention in the gut. And then as a result, they get hyper-fluoridosis. And you can see here the bones became much more dense over the past 6 years.
Yeah, that's very interesting. It really does simulate, at least on these images, renal osteodystrophy. Sometimes you can get a very florid periostitis and periosteal in your bone with voriconazole, which will help to separate it from renal osteodystrophy.
That was
this one almost looks renal osteodystrophy-like.
Is this the same mechanism as, because I was going to ask about that hyperostosis.
Yep.
We've seen cases, but I haven't seen one now in a long time. And I didn't know, is it the same mechanism or is it different?
It's the fluoride, if that's your question. Deposition of fluoride.
Right. Does that have something to do with the hyperostosis? Because our patient had painful hyperostosis and like a positive bone
Right.
scan.
Yeah, I was wondering if it's the same thing too.
But I haven't seen it in probably 8 years.
I think we've probably each shown one case over the last few years.
Yeah. And I wonder if there's been a change in the formulation or something.
Yeah, no renal insufficiency with this guy, and no reported pain at least. This case, this is kind of a fun one. This is a guy with a lipomatous hypertrophy of the interatrial septum, which you can see nicely here in an exam from a couple of years ago. And you can see he also has some aortic valvular and mitral annular disease. And so he underwent operative repair of both of those. And the post-operative CT is interesting because you can see where sometimes you'll see like a little bit of dirty fat, probably some volume averaging, or maybe a higher attenuating component of lipomatous hypertrophy of the interatrial septum, like you can see here in the top left image. But now on the postoperative study, you can see this peripheral rim of increased density, which is new from prior, and it's still very centrally very fatty. Maybe a couple little areas of striations there. So I think this is probably a good look for fat necrosis. Certainly, if it was in fat necrosis in the breast, this would be a classic look where there's peripheral, either peripheral enhancement or cystic spaces, and then or a cyst-like epithelial lining, and then centrally fat. And you can see it nicely here also on the CT abdomen pelvis, just how centrally fatty and peripherally non-fatty it became after surgery. And they did cut through the interatrial septum when they were doing the mitral annular repair.
Do you think he has pain with
Jeff, if you can scrub that last case from the slide, I had some PHI on there by accident.
I'll take care of it. Thank you.
Thank you. I'm sorry, David, what did you say?
I just wonder if that was painful, the way necrosis of fat is painful when you have that in the anterior medial sternum.
Oh yeah, I bet it's probably pretty painful to have heart surgery. I think it occurred probably in the OR, so he's probably anesthetized at the time. I don't know if he was painful postoperatively at all. Let me sorry, now I can pull it back up now that I had another case pulled up. There we go. Yeah, I don't know. That's a good question. I can certainly look into that.
That's an interesting observation you made. Curious.
Yeah, I don't know what else it could be other than fat necrosis. Why else it would be so peripherally? Why the attenuation would increase peripherally like that?
Iatrogenic ischemic. Huh, interesting.
Those are my cases.
All right, thank you.
Jeff, I have one acute one to show.
There you go.
Okay, can people see a set of radiographs and CT scans both?
Yes.
Good.
Dog. So let me show you this young man. I think he's about 25 years old. This exam on your right here is from a few years ago. I think this is 2017, so 3 years ago. He does have these ill-defined blobs in his upper lungs. This is the earliest radiograph we have on him. And then his more current radiograph, this is from, I think, October 2020 now, shows a lot more of these blobs here in his upper and mid lungs. And let's go back to a CT scan in 2019. So this is October 2019. And you can see that these upper lung lesions here are some blobs that seem to be maybe around airways, and then there are some low attenuation components to it too, maybe some cavitation associated with it. So interesting lesions that sort of taper off as we get to the lower lungs. And then things are worse now. So this is a more current CT, and you can see that there are all of these stringy blobs in kind of like a sarcoid peribronchial distribution. Bizarre stuff. So, what do you think? He also
Based on
has
the
some
radiograph, I was gonna say chronic eosinophilic pneumonia because it was kind of that reverse bat wing, but no, with cavities and what you're showing here, I don't think so.
And David, what's
Okay.
the time frame again? Like, it's just what, 2 months, a month?
So this is for the radiographs, this is 2017 and this is 2020. So 3 years for the radiographs. And then 2019 for this CT scan. And then this year, 2020 for the dramatic one here.
Slow progression of something.
Adenocarcinoma
Does he have
is something to think about, although it's not the most typical appearance.
What was your suggestion, Jeff?
I was thinking, and he's how old again?
25.
Yeah, well, I was thinking, one of these slowly growing multifocal lung cancers, but he's kind of the wrong age for that.
Yeah. Okay, well, this
does
turns
he
out
have
to
a
be
connective tissue disorder?
He does not, but he has Langerhans cell histiocytosis based on lung biopsy. So this is LCH, and at his age, it's often one of those childhood versions, literacy, we are Hanschul or Christian. He has bone disease too. He had a hearing problem with a mastoid lesion. He's got skull lesions and so parietal bone lesions, and also pelvic lesions and some rib and scapular lesions, which I wasn't able to pick up right away on the CT scan. So this is a Langerhans cell histiocytosis unrelated to cigarette smoking, although he was briefly a smoker. So he is treated with, and I think cytarabine or one of the chemotherapeutic agents. They have looked for a BRAF mutation and have not found it. There can be mutations in this MEK pathway as well, which is, I guess, related or upstream or downstream from BRAF. So that hasn't been looked for yet, but there was in October, there was a lung biopsy and they did the BRAF testing on that. So evidently they can do targeted therapy if they can find a molecular pathway mutation, but evidently those responses are maybe not so durable, so they're happy to treat them with the chemotherapy agents currently. And a more recent chest radiograph than the dramatically abnormal one here from October has shown some clearing now that he's put back on this chemotherapy agent. So this stuff has cleared up a little bit on the most recent radiograph, which I saw this morning. So this pattern on this CT scan here, where there's dramatic worsening here, really suggested to the people in our department who read this that there was some malignant transformation into lymphoma or something like that. Or, I mean, this really looks so aggressive, doesn't it? But it's thinned out again now that he's gotten this chemotherapy. So we don't have a new CT scan to show that clearing now. So a dramatic case of Langerhans cell. So histiocytosis keeps surprising. It's practically my favorite disease. Let's go with histiocytosis, everyone.
It's a really
Wow.
good case.
Wow.
Systemic
That's
dispositive disorder.
And the PET, he's had numerous PET CTs over the years, and the PET lights up in these areas in lung and bone. Okay, that's it, Jeff. Thank you.
Thank you. Wow, that's a great case.
That's
All right.
crazy.
Travis needs to leave a little early, so we'll let him go next, and then Vasilis has his case. We'll do that one for
Thanks.
Travis.
Well, I'm going to change up the order then and start with this one. You should see a CT now.
Yep.
Good.
Yep. What happened? Was there? You see it or not?
I see the top image.
Okay.
And your
there's
mouse
some,
moving
I'm getting
around.
some disclaimer. Okay, no, okay. Some other weird window that GoToMeeting has put up. What the hell's going on here? Let me stop sharing and then try it again. It says, please close confidential windows. All right, I have no idea what's going on. Huh. All right, go to Vasilis' case. Let me just bail out of here and come back.
All right.
I don't know what's going
Vasilis, you
on.
can show your case, and then we'll come back to Travis.
Hey, can you see my screen?
Yes.
Okay. Also, I'm having overlapping windows. I'm trying to minimize them. Okay, so wait for a minute. Okay, so this is a case of a 67-year-old male. I'm not going to withhold any information, but I'm just gonna present the case as it eventually rolled out. So he's a never smoker. He came to us because he had a diagnosis of rheumatoid arthritis, and we had to evaluate him for his lung involvement due to the rheumatoid arthritis. And I'm just scrolling through the CT, so there are diffuse granulous areas and bronchiectasis, rather severe. Actually, he has a progressive disease. The patient started experiencing dyspnea over the last 5 years, and he's in respiratory failure for the past 2 years. While we were digging up the history about how the diagnosis of rheumatoid arthritis was actually put, we came across a very strange finding. So he had a rheumatoid factor that was skyrocketing. So it was, the rheumatoid factor was 9,400 international units per ml, which is a huge number. I just remind you that the upper limit of normal is 15. It's worth remembering that actually rheumatoid factor is an IgM antibody against the Fc portion of IgG. So from a clinical perspective, when we're facing such an enormous increase in rheumatoid factor, we always think about the possibility that this is actually a monoclonal IgM that is produced by a monoclonal population of plasmacytes. When we dig up even further to the history, the patient for the last year, he was seen by a hematologist about an IgM M-gas disorder. Putting this all together, we managed to get this CT. So the CT that I show you, this one is in December 3 in 2020. So this CT is 5 years earlier, and looking for light chain deposition disease. Scrolling through this CT, I think the thin wall cysts are clearly evident. So I think that this is a different pattern of disease. Again, we have diffuse granular opacities, but I think if someone scrutinizes the CT, he will find these thin wall cysts in the right and also in the lung left. And also the whole distribution of disease is diffuse. So all of the lobes are involved. So again, I'm scrolling down, and I think that besides the airways involvement, it's a mixed actually type of involvement. There's parenchymal involvement in the form of cysts, but also there is diffuse airway involvement. And again, so there are actually cysts everywhere. And like in the left. And so based on this finding, on the imaging findings, we sent for further evaluation, and immunofixation actually proved that he has a monoclonal IgM, kappa light chain actually, and he was referred to hematology, and the final diagnosis based on bone marrow biopsy was Waldenström macroglobulinemia. I would love to have a tissue in this patient, but he's in respiratory failure. So I don't know if you're agreeing that this is a light chain deposition disease in the lungs.
It's got some of the features, and I've not seen one with airway involvement. I know Howard probably has more experience, but could it be like a mix of a follicular bronchiolitis and a light chain deposition?
Yeah. The problem is that we're not ever going to have tissue by diagnosis, unfortunately. But what I find very intriguing in this case is that it's evolving, and I find in the literature, and there was an excellent article by Professor Howard Mann regarding this entity. So this is the article, okay, about cystic lung diseases. And what really struck me is that in some cases, there is also lung involvement, actually airway involvement in the, like bronchiectasis. This is like, so sometimes we have a coexistence of cysts and bronchiectasis. And this is the final CT in 5 years later. And I think that there are very striking bronchiectasis as well. Like in this area, it's like a diffuse bronchial thickening in both lungs. I think that because it's a progressive disease, now the cysts are not so evident after 5 years. So it's a mixed pattern, and I would really love your input on that. So, like this is a cyst.
I agree with Jeff. I wonder if there are two different things here. If there's a primary airways abnormality like follicular bronchiolitis.
Yeah. So I'm putting this, yeah, like, let me sing this. Oh. Okay. But I think that in the first CT 5 years earlier, the cysts are, these thin wall cysts are evident, and having the diagnosis now of Waldenström macroglobulinemia, is there any other thoughts about what these cysts could be?
Yeah, it's very interesting. There also seem to be areas of hyper-attenuating lung, particularly in the left upper lobe, where
yes,
the vessels are very small. Here. And just looking at that area, just for example, it's almost suggestive that there is bronchiolitis obliterans in that area potentially, because the vessels are small, the lung is hypo-attenuating. It's very difficult.
And yet there is also, and yet there is also cysts in this hypoattenuating area.
Yeah. Maybe.
So, would, based on your experience, would you, based on the findings in 2015, would you call this image consistent with the light chain deposition disease, given the fact that the patient has, as it turned out, macroglobulinemia?
I think it's a reasonable thought. I've never seen a case of such florid bronchiectasis in which the walls of the affected airways are so thick. That's odd. But then the cystic spaces are certainly consistent with protein deposition.
It's also striking, I think, that it's the bronchiectasis in the last CT of 2020. There are so diffusions in. At least I've never seen such a diffuse and clear thickening of the bronchi. Yeah. Like in this area.
Right.
And I'm also aware of an article in 2008 that I think it's this article, and you mentioned it, Professor Mann, in your references in the article that I showed about this patient that he had mainly bronchiectasis, and it was again due to light chain deposition disease, as it proved out to be by tissue confirmation. If you remember the paper. So, okay, because I don't want to see zebras in my clinical practice, I don't know how can you provide me guidance if I'm seeing zebras or not in this case.
Yeah, it's very intriguing, particularly given the diagnosis. A satisfactory diagnosis is to attribute it to the deposition of light chains in the lungs, because that seems the most plausible explanation.
Okay.
So that's very
we will have to go. We will have to go with a probability diagnosis, because we will not be sure. Because I don't think that this patient will ever be subjected to biopsy in a safe manner.
Right. Exactly.
And also, I would also like to really stress out the value of imaging, because as a clinician, there's not much that clinical examination can give to you. The extremely increased value of rheumatoid factor was actually very helpful. But digging up this image from 2015 and seeing the cysts really brought out the possibility of lymphoproliferative disorder in this patient.
Yes. Gosh, that's an interesting case.
Yeah, thanks for sharing.
Vasilios,
thank you very much. Yes.
What did he really have rheumatoid arthritis symptoms? Is that a clinical diagnosis?
No, exactly. No. It was a laboratory diagnosis, and therefore a wrong diagnosis, if I may. We really searched him. He had absolutely no evidence of arthritis.
Yes.
And from my clinical perspective, I think that he had maybe a smoldering IgM Waldenstrom macroglobulinemia that was just going under our noses.
Yes. Yes. Very, very interesting.
And the cysts actually were the main help in suspecting the correct diagnosis.
All right, well, let's go on to Travis so he can present his case.
Okay. Thank you.
Thank
Very
you.
interesting.
All right, let's see. Okay, let's see if it works now. All right, do you see my screen?
I do.
Okay. This is one that is a recent case, and it's not uncommon, I think, for any of us to get the history of some sort of neurologic symptom, or in this case, it was an ocular, quote, lesion, evaluate for primary malignancy or metastatic disease. And this patient had, I guess, bilateral intraocular lesions. I don't know more information than that at the time. And this was the CT.
Retinopathy or something that suggested it could be a paraneoplastic ophthalmologic condition?
No, it wasn't a retinopathy like a paraneoplastic. It was more like evaluate for sarcoid, evaluate for granulomatous disease, or evaluate for cancer.
Okay.
But this is the CT, and you can see there are these upper lobe fuzzy, predominantly they're fuzzy ground glass nodules. A lot of them are along the fissures, so it's really kind of hard to say, is this all centralobular, or is it, is it more of a perilymphatic distribution? I guess I would tend to go more with the latter, that these are probably in the lymphatics, just because as you move down further, you can see there are a lot studying the fissures. And that was it in the chest. You'll see that there are a few liver lesions that don't look sarcoidish. They certainly look like they're metastases or malignant of some cause. And so we were kind of scratching our heads with this one. My first thought, the first thing I thought when I saw this, not knowing anything else, was wondering if this was going to be some sort of metastatic pulmonary calcification. She had no history of renal insufficiency, had never even had a hospitalization where she could have had even transient changes in her calcium and phosphate balance. I was wondering maybe sarcoid or some sort of granulomatous process with the history. I'm curious what anyone else thinks.
I think it looks like sarcoid, but there's a pericardial effusion, which is kind of rare in sarcoid.
Yeah, a little bit of fluid, I agree.
The nodules are very much ground glass attenuating, which is certainly unlike usual sarcoid, where the coalescent nodules are more attenuating.
But Howard, you showed a very nice ground glassy case last week.
I did. That's in a category of.
Yeah, sarcoid is a cause of ground glass.
And there, a lot of them are along the. Look at the fissure on the left, Travis. It's kind of nodular, and the subpleural lung is involved. Yeah, look at that right there.
We weren't sure, and at the end of the day, said maybe sarcoid, biopsy the liver if you need tissue for something, because those look like more discrete lesions. If this truly was an intraocular malignancy. So they did a liver biopsy, and the liver came back as diffuse large B-cell lymphoma. And I'm wondering if this is all lymphoma. Now, unfortunately, we don't have a follow-up yet. We will get one, as she recently started chemotherapy. But I'm curious if anyone has seen lymphoma manifest like this in the lungs.
No.
Could it be a sarcoid reaction to the lymphoma?
Yeah, I don't know. But yeah, just totally bizarre. So
yeah, the concurrent sarcoid lymphoma syndrome, so-called, people sometimes talk about that concurrent lymphoma sarcoid syndrome, as it were. Gosh, that's unusual.
So really unusual. I think we're all kind of on the same thought process, though. And I think that eventually they thought her intraocular stuff was related to the lymphoma as well. So really weird. All right, and then this one. So this is a patient. I'll just show the baseline CT. At baseline, this is a patient that has this large right upper lobe cancer. It's an adenocarcinoma. They have huge lymph nodes, probably have an additional adenocarcinoma, at least one on the left. At this time, this was back in October, they have a tunneled pleural catheter for a malignant effusion. Between this study and this next study that was done a month later, they developed an empyema from infection of the tunnel pleural catheter, ended up being removed, and then they had the empyema. So I think that the catheter was infected, then they took it out. Let me get that off. So then they came back in and had a pigtail pleural catheter placed, as you see here, for drainage of the empyema after the days or weeks after the tunnel pleural catheter was removed. And this tunnel pleural catheter has somewhat unusual configuration. And if you note the lung here at the right lung base, almost looks like it's a little infarct here, where you've got some central ground glass in that lung and a little bit of rind of the higher attenuation like we see with a pulmonary infarct. And this is just a non-contrast study, and nothing was really commented on at the time. I will show the next CT just a few days later. And now the patient has blood in the pleural space as well. And my colleague Kim saw this one and wondered and said, I don't like the course of this catheter. They had put TPA into this catheter trying to break up the empyema. And she thought, based on the course of the catheter and the look on this one, that this was probably going through the parenchyma and causing a little bit of hemorrhage, which is what's giving that lung in the posterior and lateral basal segment that look. Now, I was showing this because I think probably there was a little bit of adhesion. I don't know. This was a little bit of atelectatic lung at the base before. And so I suspect that when they put this catheter in, that they just speared this little bit of lung at the base that was previously atelectatic. This was a follow-up they did with contrast after this, the hemothorax. And you can see, I think now without a doubt, that this clearly is going into the parenchyma. I can show this one in multiple planes, but it was just a good pickup on my colleague's part of this being an intraparenchymal chest tube placement. As you can see here, it's just looped around, in the basilar segments of the lung. And I suspect when it was placed, it was just pushed through those adhesions. And then they did remove it. This is a more recent one, just to show you that you can see that consolidated lung and a little bit, I think, of the tract right here. So more iatrogenesis with a little bit of an intraparenchymal pigtail catheter placement. And I will stop there, Jeff.
All right, thanks. Let's see, Howard.
Travis, while Howard is getting ready, I think you showed a case of some cysts that weren't completely empty in the setting of LIP. Was that you who showed that in the last couple of weeks? You were commenting on the cysts not being absolutely empty.
No, I can't remember. I showed the central lobular emphysema that kind of mimics cystic lung disease.
Got it. Okay.
It may have been Seth. I don't remember.
Okay. Yeah, I just came across a similar case, and I just wanted to bring that up, that I think that in the setting of LIP, the cysts are sometimes, they have an emphysematous look to them, meaning that you could still see some tissue strands in these holes in the lung, even though the holes are fairly discrete. So I think that may go with the particular kind of lung digestion that maybe goes with LIP or light chain disease. Sorry to interrupt.
Okay, this first case is a nice demonstration of what, if you know the history, is not a mystery, and that is these are metastases from an osteosarcoma that contain osseous matrix, and they are most numerous in the right lower lobe. But I want to show you an image from this being last year, and this is from the outside institution, so this goes back to July of 2019. These are 5 millimeter section thickness, and if I scroll through that in the usual way, of course, a bit faster than you would at the workstation, it's rather unimpressive if you look at it at that speed. And I will show you that they did get in their protocol MIPS coronal, but I don't see 1 millimeter cuts. But anyhow, this shows the value of what we all know, which is in the context particularly of oncology, getting MIPS. So I don't think he was known to have or came with a history of metastatic disease. So a couple of cases here. And if I make that bigger, you can see that these are branching tubular opacities. And I'll just change the window width, and you can appreciate that you can see that there is hyperattenuation associated with those. And then I'll go to this one and show the same thing. So again, This is branching tubular, where we have the larger opacity recently. And again, also changing the window, you can appreciate that. So these are intravascular metastases. They've grown over that period of time. And that shows the value of MIPS for oncology imaging. I think we certainly all do that for oncology imaging. I think there's also value also to having 1 millimeter section thickness as well. I think we all do. Yes, there's a lot to look at. But one of the value of having 1 millimeter section thickness is that on MIPS imaging, sometimes you, in a sense, see too much, that you see these 1-2 millimeter nodules that are few in number. And sometimes, if you look at the corresponding 1 millimeter thick sections, you can appreciate that it represents interluminal material in a small airway, presumably some kind of inspissated mucus. And if you can identify that, and I've shown a few cases in previous webinars, then it helps you identify that those lesions are benign. So just some interesting findings in terms of protocol, the value of MIPS, but also, and I can show some examples another time, of the value of having 1 millimeter section thickness as well.
Howard, that's a great case of intravascular metastases. The coronal MIP, I showed a similar case a few months ago, and you'd recommended coronal MIP, so I started making them too, and they work really well. I'd say the one downside of the way they did this one is, yes, you can see it looks like they did a lung kernel on your MIP, and so if you use a sharp kernel like that, then it ends up being really noisy and hard to look at. And so if you use this one isn't the noisiest kernel, but if you use a softer kernel, like a soft tissue kernel, a lot of times the MIPS like these will be a little bit easier to look at and see, especially while you're scrolling through, looking at the vasculature.
Right. And we used to, when I first started, now we still get axial MIPS, which I think is okay compared to coronal. But then there's a debate as to whether, as your default, you should get 10 millimeter thick MIP slabs, or maybe 5 millimeter thick slabs. And perhaps 5 millimeter is a bit better than 10, but I don't have an evidential warrant for that. It's just what we've evolved to do. So our MIPS are axial, and they're 5s rather than what we used to do years ago, which was 10 millimeter slabs. But there's a trade-off. But MIPS are certainly useful for a case like this, not only to see things, but also to identify the nature of them. Yeah, in a case like this. Right. This is an interesting patient. The background here, and I'll show you some more clinical information in a moment, is a patient that had a renal transplant in 2019. So many months out. She came in with an acute respiratory illness with a chest radiograph that shows this large opacity in the left upper lobe. And it's an acute febrile illness with a cough. And let me show you what that looks like. It is large. It has a little bit of ground glass opacity in its periphery. Interestingly, here and there in that lobe, which I find kind of interesting, are septal lines as well. And looking at the interior of it, there's no cavitation. That's the pleural surface. And certainly in the context of renal transplantation, and the fact that when I read the clinical notes, I got the history that over the last, I can bring this up in a moment, while she's been traveling very extensively in a van related to her work. So she's been in many states, including the southwest part of the United States. One would think of opportunistic pneumonia, and this turns out to be via a CT-guided biopsy. This is a GMS stain showing Cocci. So somewhere along the line, she did acquire a primary Cocci infection, and a nice GMS stain showing that. I'm not sure why there's interstitial edema. I've seen that sometimes before in the context of opportunistic fungal pneumonias, but I'm not sure It's interesting, there's another nodule right there. Why that sometimes happens, I think we've all seen that before. I don't know, somehow maybe these nodes are involved because I don't have contrast. So one could potentially speculate that there is sufficient nodal involvement here such that lymphatic drainage through them is impaired, and therefore one pathway for lung fluid clearance is somewhat compromised. But that's just speculation on my part as to why one might get interstitial edema as well.
Alternatively, Howard, there just may be increased lymphatic drainage because of all the inflammation.
Yeah, something like that. Yeah, you can see fluid in the bronchovascular sheath in relation to a few bronchi too, right?
Yeah, it's like all the lymphatics are, because we see that with like incidentally detected acute histoplasmosis. I mean, we typically see a much smaller nodule, but you'll see little nodules along the lymphatics, and sometimes you'll see a few septal lines along the veins. And I suspect it's just lymphatic drainage. Now, your case has much larger lymph nodes, so there may be a component, because that airway looks a little narrowed. Makes you wonder, and if there is just, if the lymph nodes are replaced with inflammation, they look pretty low attenuation there, that there may be, it may be a mix of impaired drainage, but also increased lymphatics.
Right, something like that. But we've certainly seen that.
You know, I think I've been at some institutions where there's a hesitation to stick a needle across the pleural space in something that could be cocci, just because of the danger of seeding the pleural space, having this infection get into a bigger compartment.
Hmm.
The question I had was if you were to biopsy this, what would you target? Try and hit the center or the rim, the periphery?
I guess kind of anywhere here in this one. There isn't obviously a lot of necrosis in the middle of it that I can tell.
You don't want to go to the middle of these things. They're all necrotic.
Maybe try to avoid the middle here somewhere.
But isn't necrosis good for microbiology?
I don't know, actually.
I don't know.
That's a thought.
Yeah, because this comes up every now and then where I have something that looks like this, and you know, I'm like flip a coin whether it's going to be some kind of infection or tumor, and you know, for tumor I usually try and go for the edge, the periphery, especially if there's a PET, and then if that comes back negative for tumor, then you know, infection's still really in the differential, and a lot of times they have a hard time drawing it from the stuff that I hit on the edge.
Okay, Jeff, I'll stop there. I've got others, but I'll stop there for this week.
Okay. All right, I will show a couple. Let's see. All right. Waiting for, that's weird. Let me try this again. It says waiting for next screen. I don't even know what that means.
Waiting for next screen. That's odd. We're seeing weird error messages from GoToMeeting.
Yeah, my GoToMeeting, it did some update or downgrade. I have like the old interface running. I tested it earlier and it was showing my screen. So this is very, okay, let's see. It says we'll show the screen. I'm going to change the presenter back to Howard just real quickly and then take control again, see if it works.
Can't say anything.
Yeah, I don't know why. It says it's sharing, but it's on the little thing. All right, well, who else is on? I thought I saw Seth on. Seth, are you there?
All right, I'm here. Unfortunately, my cases are not, actually, no, I think I can show this case. Yeah.
All right, I'll give you control here.
I don't think there's any HIPAA information on this. So this was a young patient who came into the emergency room. Now, I don't really understand a lot of stuff that, you know, the general teaching is if someone comes in to the emergency room and they have chest pain and a positive troponin, you take them to the cath lab, but I guess that doesn't seem to be the rule here. This patient was a young patient. She was postpartum. She was breastfeeding her baby and experienced severe chest pain, came to the emergency department and had a very elevated troponin. And they decided to like kind of sit there and treat her with some beta blockers and anyways, and then eventually someone thought about getting a cardiac CT, which again is probably not the best study for this. Well, it's a good study to see it, but it's not she should have gone right to cath. But nonetheless, you can see that there is here that this very kind of strange long segment narrowing. There's no real disease anywhere in the coronary arteries, completely normal. So this is another, and you can see here, this kind of a soft tissue, kind of eccentric soft tissue surrounding it. And then you can see the vessel basically almost completely going away and then coming back. Whoop. Thing just popped up in front of my screen. So this is another, this is just another SCAD. We've had a couple of these in the past. Can you guys see my stuff, or am I getting these weird flashes?
No, we can hear you. The screen did disappear though, but we got to see it at least.
You see it now?
Back again.
No, was it there at all?
Yes,
Yeah, we saw at the beginning.
And then it just, all of a sudden I got these flashes and it gave me okay, anyways, I have no clue. But you can see here the vessel goes away. And this is just another SCAD in a young patient who is postpartum. And actually we had another one. So 2 weekends in a row, we had 2 SCADs. And here is the associated, let's see if I can stop it and show it to you. It's this right here. So, you know, and they just treat these, they don't really mess with these. Again, here you can see it. You know, unless it's completely occluded. I'm surprised that they didn't put a stent in this here. But the general, I think there's kind of debate. I don't know if Travis knows. I think there's kind of a debate about what to do with these if someone's actively infarcting, if you just treat it conservatively, i.e. just with kind of beta blockers and anticoagulation, or if you go ahead and stent them. Here they tend not to stent them. Even in this patient had wall motion abnormality. You can see there's some thinning of the anterior wall. But just another SCAD case.
Okay, so Seth, basic question.
Yeah.
What is SCAD?
Oh, it's a coronary dissection. Spontaneous coronary dissection, sorry. So spontaneous coronary dissections are most commonly seen in young women, classically someone who is peripartum or postpartum, and there's a various classification for them. Most of them I see kind of look like this, where you can almost imagine that it's like an intramural hematoma surrounding the vessel, compressing it. Occasionally you'll actually see a true dissection flap in the coronary artery. And I think might be someone subtyped them into 3 or 4 different classifications based on if there's a flap or intramural hematoma or entry or re-entry sites, so on and so forth. But they're can be, you know, they're pretty devastating. You know, they lead to usually infarcts, sometimes sudden cardiac death, depending on where they occur. And, you know, the other one we had, I wasn't 100% convinced. It was called SCAD, both on cath and CT. It wasn't as classic, clear for me, but. Do
you think there's is there some ischemia along that, the anterior left heart border there? Is there some?
But yeah, no, there's definitely, yeah, if I had the cine up,
I think in that lower right picture, it looks to me as if there's ischemia along the.
Well, she's infarcting.
Okay.
So you could see, I mean, I mean, it's ischemic, at least ischemic. So there's all this hypoattenuation in the LAD territory. You can see it's starting to, it looks a little thin compared to the base. This is right, I mean, this is a nice picture, right? Because you see right where the SCAD becomes occlusive, you start seeing the right here to the, from here to the base, it looks normal and it pumped normal. Right here, distal to where it becomes occlusive, you see this hypoattenuation along the LAD territory, and this somewhat starting to become a little bit thinner. And this whole area was severely hypokinetic.
Thank you.
Yeah. Does anyone know whether, not in the acute setting, but subsequently, they're imaged quite intensively for fibromuscular dysplasia in the carotid artery, in the abdomen, the renals, and so on and so forth?
Yeah, so that's, you know, the work, right, you're right. Since there's such a common association with FMD, they usually go have an extensive workup for that. One of my colleagues actually had a SCAD and wasn't very good. She had a SCAD and they did an extensive workup for FMD, just to make sure she didn't have that.
You can't treat the FMD, right? You're just basically putting it in context, right?
Yes, from my understanding.
Yeah.
And Jeff, is your thing working, or do you want me to try to show another case?
Oh, sorry, I muted myself. We have time for one more. Mine's not working yet.
All right, let me pull this over here and just pull this other case up. And sorry, there's lots of images here. Let me find the right image. So this was interesting. I'd not seen this on CT, and I'm trying to find the delayed image, which kind of shows it nicely, but I can't see if I can find it here.
There's still screen left, I think. There you go.
Yeah, no, I was just making sure there's no information here. So this is a patient who has, you can see that this LV is quite thick. There's kind of circumferential hypoattenuation of the myocardium here. Kind of has that classic, it just looks like a stiff heart, kind of has that classic amyloid look, which he does have amyloid. What was interesting to me, I don't think I've ever seen before, was we know we see kind of atrial enhancement in a lot of cases of amyloid, and you know, we just say that's just atrial wall involvement, but look at the soft tissue here, kind of around the left atrium, all this abnormal soft tissue just surrounding left atrium, which presumably is secondary to amyloid. I just don't think I've ever seen it to that extent on a CT. I mean, again, I don't have that many CT examples of raging amyloid. I don't know what subtype of amyloid he is, but I just don't think I've seen that before. I thought that was just kind of an interesting manifestation of amyloid that we probably see more frequently on MR with the atrial enhancement. I just don't, yeah, that's about it.
So you're thinking that's a very thickened atrial wall, pretty much?
Yeah, so this is all abnormal soft tissue.
Yeah.
All here, all this stuff.
Wall. Yeah.
here. So again, I'm not sure what subtype he has. He's a younger guy, so we don't have an MR on him, but I'm assuming that that is related to his amyloid, which is biopsy proven. He has it like all over the place, renal, skin, so on and so forth.
I don't know much about it, but I've heard that there are a couple ways of quantifying extracellular volume by CT. And apparently there's a way of doing it even with just a multi-phase single monoenergetic CT like this.
Yeah, maybe there is. I have to. Yeah, I don't know not much about. I know people have done that, but no, not too much utility. I mean, he's got the diagnosis, but yeah, no, I know that there's research being done on ECV with CT. I think you need I thought you needed a delay study too, but maybe I'm wrong. Anyways, Jeff, those just 2 quick cases.
All right.
Very good.
Thanks, everyone. We'll try to fix some of these technical glitches for next week. But everybody have a good rest of your week, and I'll talk to you next week.
All right, thanks.
Thanks,
Bye.
everyone.
Bye.